Okay, class, we're now going to talk about cardiac output. This is an essential calculation because it shows how much blood is being put out from the pump, the heart. It is essentially generally in milliliters per minute. That means how much blood is put out in 1 minute. How much blood is put out in 1 minute from the heart. Okay. So cardiac output is the volume of blood put out by each ventricle in 1 minute, which means we have two ventricles. Cardiac output equals heart rate times stroke volume. Okay, both sides of the heart need to put out the same amount of blood. In other words, there would be a disparity. So going into the lungs ought to be the same amount that's going into the aorta. That's why they say each ventricle. All right. So cardiac output equals to heart rate times stroke volume. Heart rate is the number of beats per minute. Stroke volume is the volume of blood put out by a ventricle during each beat. Okay? Stroke volume equals to end diastolic volume minus end systolic volume. End diastolic volume is the fullest the ventricular chamber will get before it contracts to empty. Contract to empty means that's ejection contraction. End diastolic volume is the emptiest the chamber is after ejection contraction. Now I put some numbers here. This is kind of a usual type of thing. Okay? So normal stroke volume is about 70 mils for each chamber. That's kind of the average. So cardiac output then is about 5 liters per minute. Now what that puts us at, if you think about it, the average person has 4 to 6 liters of blood on board. 4 to 6 liters of blood on board. So therefore it looks like you pretty much circulate your whole blood volume in a minute. And that's the average. Now, if you start exercising, it can go much higher because your heart rate will go up. You'll squeeze down harder. So it can go very high. So cardiac output can increase significantly. Now, we can see how heart rate could go up. Okay. But what about stroke volume? Okay. So now we're looking at the regulation of stroke volume. Now, these are the 3 things I want you to study on, which involve muscle. Preload, afterload, and contractility. Preload, afterload, and contractility. Okay, let's think about this. Let's say I'm in class and I'm standing next to a gentleman about my same size. We both have a 100-pound barbell in front of us. We both have a 100-pound barbell in front of us. Okay? Now, I'm standing there. He's the same size. Let's say we're going to lift the barbell. Let's assume he has the same preload. The preload on my biceps muscle would be the weight on my biceps while lifting the thing. You say, what is that? The weight of the bones, the tendons, the epimysium, and everything. There's a weight on your muscle before you lift anything. The afterload would be the weight I'm going to lift. And so we both are lifting the same weight, 100. He throws it up much faster. That means he has better contractility. That means he can contract better even though we normalized, equated for preload and afterload. Okay? Contractility in cardiac muscle, is called the inotropic effect. Contractility in cardiac muscle is called the inotropic effect. So we could have drugs that strengthen the squeeze of the heart, known as positive inotropic drugs, and we could have some that weaken the heart, negative, if the person had high blood pressure or something, and we need not to make the heart. So this preload, so if we look at the heart then, so now we're looking at the heart and saying, what then? I used it for skeletal muscle. What is it for the heart? Okay, the preload would be the volume of blood in the ventricles before you squeeze down. The weight of the volume of the blood, the tension of the volume of blood, whatever you want to call it, before you squeeze down. That's the preload. The afterload, like the 100-pound weight, is what you have to work against. What do you have to work against the right ventricle to empty? That would be the pressure in the pulmonary artery. The pressure in the pulmonary artery is what you must overcome in order to push blood there. On the left side, you have to overcome the pressure in the aorta. So the afterload is the pressure in the next chamber. The afterload is the pressure in the next chamber you're trying to push into. Contractility is how hard can you squeeze despite the preload and afterload. Okay? So if you had a weak left ventricle, one way we could do it is to give a diuretic to weaken the afterload, pull some of the fluid out of, let's say, the aorta, pull some fluid out of the aorta. Okay, so preload, afterload, and contractility, but you can never use the word inotropic unless you are speaking of the contractility. Now, here are two words for you. Chronotropic, C-H-R-O-N-O-T-R-O-P-I-C. You can see that in the book. Chronotropic, which is chronology kind of, speaks of the speed of the heart. Inotropic speaks of the force of contraction. So we have things that speed up. Positive chronotropic drugs. Positive chronotropic drugs. Now, what normally is the main controller of the inotropic in the heart? The availability of calcium. Calcium is the main thing that controls that inotropic. Okay? Now, I'm going to go to something else, and this is called the length tension curve. Now, you saw this in skeletal muscle. You don't want the heart. Now, this would be an example of a sarcomere. Go back and study, I can't do everything. Go back and study sarcomere. There's a reason that if you tried to lift a weight and your arm is too far out, it's weak. It's too far in, it's weak. But there's an optimal distance that you would stretch your biceps to lift something. That has to do with the sarcomere. Now, in here, this would be an example of myosin, that right there. This would be actin right here. That's myosin, this is actin. If you were too far in, you wouldn't be able to get that actin to bind to that myosin. Here, you're too far out. So here's an optimal. So with the heart, you don't want to get it overstretched, overdistended. You don't want to get it overdistended. Because if you do, somebody have to push on your chest to bring it in. You see what I'm saying? So in other words, here's the situation. With the heart, there are two things that help the heart from not getting overdistended. One was that fibrous pericardium I mentioned. That fibrous pericardium, which was around the heart, tries to hold it. The other is something called Frank Starling's law of the heart. I want you to look up. Frank Starling's law of the heart. What Frank Starling's law of the heart says, as you stretch heart muscle to a certain extent, it will contract harder. As you can stretch heart muscle to a certain extent, it will contract harder. So the Frank Starling and the fact of the fibrous pericardium assist in that particular activity there. So here again is preload. The degree of stretch of cardiac muscle before they contract. See, if it stretches too much, you need to invoke Frank Starling's law of the heart, or it will mess up this length-tension relationship, and you won't be able to contract because it will be too far out there. Okay, so I want you to study on that. Preload, afterload. These are things that I want you to kind of do some on your own now. Preload, afterload, contractility. Preload, afterload, and contractility. Okay? Now, when it comes to contraction of the heart, most of the calcium comes from the outside. Unlike skeletal muscle, where all the calcium is on the inside, a lot of calcium comes from the outside because you have calcium channels in the cardiac muscle. You have calcium channels. And this calcium comes in once the action potentials go down, and even cause the release of internal calcium. Now, go back to your skeletal muscle in ANP1. Remember, calcium has to combine to troponin C. And it's the same way in cardiac muscle. It has to combine to troponin C to get a contraction. The more calcium, the stronger the contraction can get. The stronger the contraction. So that's why in cardiac muscle, we can give calcium channel blockers. See, skeletal muscle, all the calcium is inside the cell. But in cardiac muscle, we can give these calcium channel blockers, which would lessen the amount of calcium. That would be a negative inotropic agent, which could be given in hypertension. The person had high blood pressure. To kind of weaken the force of the heart to bring some of the pressure down in the blood vessels. So we're going to talk a little bit more about the calcium in a moment. So we have positive trinotropic factors, increase, and negative. Okay. Now in a moment, remember I said that the heart had autorhythmicity. What I want to do now is to hook the autonomic nervous system up to the heart. I'm going to do it very briefly, and I want you to study on it. So I'm going to hook the autonomic nervous system up to the heart, because the heart has autorhythmicity, but the heart doesn't know when you're running or sleep. So it does need the autonomic nervous system. So we're going to look at the autonomic nervous system in the next video to see it control the heart. All right, we'll close here.